Hello and welcome to the second episode of our podcast series. I'm Anu Chakravarti with the Global Center for Youth Futures in Atlanta. To my students, I'm also Professor C. We are joined today by Dr. Eva Doski in the UK and Mr. Diari Amin in the Kurdistan region of Iraq, also known by the acronym KRI. We will talk about the pervasiveness of intergenerational trauma in the KRI, its transmission to the younger generation, and their work to make mental health care accessible and effective in the region. A small introduction before we begin. Dr. Eva is a Kurdish British clinical psychologist with over a decade of experience. She was born in Kurdistan and migrated to the UK at the age of 8. She is the co-founder and trustee of KR-UK-Impakt, a charity that collaborates with the Oxford Cognitive Therapy Center. Dr. Eva plays a key role in training and supervising therapists in the KRI. Diari is a psychologist with over 30 months of clinical work experience in the KRI. He has a BSc in clinical psychology from Koya University in Iraq. He has published articles and books on mental health, trauma, and social issues, such as adverse childhood experiences and intimate partner violence. And Diari works to contextualize mental health and psychosocial support to the Kurdish context, to bridge the gap between psychological theory and real world settings. Just a little bit of context as well to explain the significance of the issue of intergenerational trauma. The Kurdistan region of Iraq refers to the Kurdish populated part of northern Iraq. For decades, Kurdish leaders and Iraq's federal government have been in a tense relationship over issues of Kurdish autonomy and control of resources. In the 1980s, Saddam Hussein tried to quash a Kurdish rebellion with mass killings, the destruction of villages, and the use of chemical weapons, a campaign of genocide against the Kurds. Subsequently, the region experienced a civil war, then suffered the depredations of ISIS. In the post-ISIS era, the people have been shelled from neighboring Iran when the relationship between the countries turned fraught back in 2021. So Diari and Dr. Eva, welcome. Let us begin by talking about what it is that made you feel that the treatment of mental health was an urgent issue. What were you observing? What manifestations were you noticing? Diari, would you like, or Dr. Eva?
Should I go ahead
Yeah,
or
you go
Dr.
ahead, Gary.
Yeah. Thank you very much for having us. It's a wonderful opportunity, and it's a great chance to perhaps as a Kurd and Kurdish population to have our story out there because we notice like throughout the history that there's an issue of communicating what's had happened to the Kurdish population to the world, and this is a great opportunity, and there's a noble motivation behind it. So I really appreciate the chance. I think you laid it out beautifully when you talked about the Kurdish history, and for me, the Kurdish history is the pathway or the doorway toward understanding the mental health conditions or the mental health state of the Kurdish population, especially in the Kurdistan region of Iraq, which would be the southern part of Kurdistan, because Kurdistan is 4 parts and it's been divided among 4 different nations. So the history is really the doorway, and it allows us to gain a deeper understanding of what has happened to this population and making connections in terms of what we're seeing right now. And I think the main story here is that there have been multiple traumatic events, including genocide, ethnic cleansing, torture, and war and displacement, conflict, and a lot of these issues which have been happening throughout the history of the Kurdish people. And this is in addition to the absence and the lack of mental health support. So we have the issue of unresolved trauma, which kind of has formed the base of what we are currently seeing in the Kurdistan region of Iraq. And we know that this sets up for intergenerational transmission of trauma, which can be, transmitted through many different pathways. Interestingly, through attachment and parenting styles, which, if you live in the Kurdistan region of Iraq, you'll definitely notice it happening, and it has led to the presence of dysfunctional families, to the prevalence of abuse, to the the worsening of the relationship between children and parents. So kind of this has created a situation in which and let's also talk about the ISIS war and other conflict which has been going on. It's not like the conflicts have ended. So it's always about new conflict, and an increasing demand of mental health support, whereas the presence of MHP assist services is really lacking. And so yeah, that I think that's kind of the way toward the conversation. It's a combination of historical trauma and social trauma, with the absence of mental health support, contextualized mental health support, if I say so.
Right. Dr. Eva?
Yeah, I think Diori, noted that really beautifully there. It gave quite a nice context to what's happening in Kurdistan. I think for me, obviously, I migrated when I was 8. So I've been brought up in the UK, and, we had to flee Kurdistan as well. So I guess I've got my own experiences of leaving Kurdistan, and what that meant for me, particularly in terms of my identity, what, how I relate to the Kurdish community. And, going back to what Diori was saying, our parents, fled Kurdistan as well during the Anfal campaign, for example. So I could see two parts of the trauma that my family experienced as leaving Kurdistan, but also the experiences that my parents had as well. So I think for me, it's a personal journey why I'm involved in the project, and why we started, obviously, the charity KR-UK-Impakt. So for me, that's personal, but also having the privilege of being able to train as a clinical psychologist in the UK, and the experiences and knowledge that I've got here, and what I could do about that. What can I give back to help my community back in Kurdistan to try and improve some of the things that we know that are really difficult and challenging.
Right. I remember in our last conversation, we were talking about, you said that now is probably one of the more safer periods of history, but youth are the most traumatized generation. What did you mean?
Yeah, I mean, it relates to the nature of especially what we call in modern psychology secondary trauma. I think that the current, we can make a distinction between the generation before the Kurdish uprising, which happened in 1991, and after the Kurdish uprising. And we can also make a distinction between the generation between the 2000s and the generation after. I think the marked difference is that the generation before the Kurdish uprising, most of them have experienced the traumatic events themselves. They've been through it. But the newer generation, they've not experienced as many as traumatic events. But it has been intergenerationally transmitted to them, and we can observe it in terms of young people needing more support, visiting clinics and mental health centers a lot more. And this is kind of the nature of it, and especially this has in combination with social media, because social media has also become a source of secondary traumatization. So you have a population that has parents that have been traumatized, who are having children been raised with especially high scores of adverse childhood experiences, which based on the data we collected, it was above, for example, physical abuse was above 30% of the population, the data, the sample that we collected. So it's kind of relates to this idea of secondary traumatization. We have not experienced it as much as our parents or the generation before, but it has been transmitted through attachment. Like the prevalence of insecure attachment is frightening. I've been like doing clinical work and never have seen someone with secure attachment. We do some tests and assessment, and I've never seen it, which is quite surprising. Like there's an individual with a secure attachment, and it doesn't mean that everyone has insecure attachment. We can't generalize the clinical experiences, but it showcases the problem.
But Diari, what exactly is care attachment?
Well, attachment is the bond that's formed between children and their parents.
Okay.
We have secure attachment, which is the healthy kind of attachment, and we have insecure attachment, which is the unhealthy type of attachment.
Right.
And it could be anxious attachment, which, for example, individuals who go into relationships and they are always worried about being abandoned. We have avoidant attachment, who are individuals who are always afraid of getting into relationships at a time which the thing they desire is getting into relationships. So we have different types of insecure attachments, and usually it forms in the first 18 months of a baby being born. So it happens really, really early, and it kind of develops based on the response of the parents to their children's needs. But we know that children can form conclusions as early as that period.
Right. But you also said that the younger generation is something of a healing generation. What did you mean by that?
Yeah, that's kind of the idea, that the traumatized generation and the healing generation, that would be complementary, because I think barriers are breaking. Individuals are more open to seeking therapy, although it's still not enough, but services, and including therapy, mental health practitioners, are becoming more and more available, which is kind of the idea. And if you go to the clinics and the mental health centers, you could observe that the individuals who visit are mostly the younger generation. And there's also one thing that has helped us as well. The newer generation, a significant portion of them are able to speak English, which means access to information on mental health, podcasts, and stuff like that.
That's so interesting.
Yeah, that this has helped the cause as well.
Can we talk a little bit about the attitudes of the differences in attitudes between the older generation and the younger generation? Dr. Eva, you had observed older parents coming in with younger children to your clinic, and then your experiences therein. Would you like to tell us a little bit about what differences you observed?
Yeah, absolutely. I think, as Yuri's mentioned, there's been a shift with that younger generation. They're coming in more open, they're learning more. I think that's one of the benefits of having like social media and internet access. It's learning, and they're learning about mental health. But what we have is the older generation that still thinks very differently. So there's lots of different things, surrounding mental health. So, I think I mentioned before as well that, my own family members, the way they perceive mental health. And it's because personally, I think a lot of that is to do with the older generation, because of what they went through around that survival mindset. We need to survive. We've gone through wars, we've gone through displacement, really economic hardships, and they see, I guess, perhaps the mental health being a secondary struggle rather than actually the first, which is we need to survive. So if we're thinking about, Maslow's hierarchy of needs, accessing mental health support isn't the most important for them, is to survive. But also, thinking back to, when my grandparents and my parents generate, they didn't really understand much about what mental health is. And I think when we're thinking about trauma, you know, they experience so much trauma, but they perhaps, you know, felt that more physically through the symptoms. So chronic health, for example, diabetes, heart disease. So trauma, you know, when we're thinking about mental health, it's mental health and physical health because of the effect one has
on the other, right?
Absolutely. So you know, and the other part of it as well is, you know, Kurdistan is a religious community. So, you know, we have lots of different religions, predominantly Muslim. And a lot of people turn to religion, or they would turn to religious leaders like an imam, for example, if there was a mental health difficulty, or, you know, if somebody was hearing voices, you know, they would be thinking, actually, is this a jinn, for example, or is this, you know, is this person possessed? Is that why this is happening? So even with disabilities, you know, they would sometimes say, you know, I've volunteered in Kurdistan before in mental health hospitals, and they would say, oh, this is a lesson from God that my child's disabled. So the understanding around mental health and disability, one of them could be around obviously religion and turning to religious leaders as well for that support. But I think the most, you know, the thing that we need to really think about as well and consider is that mental health is seen, you know, as something that perhaps isn't, you can't see it as such as like if you had a broken arm. So, you know, with a broken arm, you can go to a doctor and they heal it. But for mental health, you know, yes, you can get medication, which still in Kurdistan is very much a medical model.
Right.
When we're perceiving mental health and working with mental health. And I think that's why this is such a wonderful opportunity for us as the younger generations, that we can really advocate for talking therapies and psychology. So I think there's also that stigma and that shame in going to a psychologist perhaps, or a psychiatrist for mental health support as well. So lots of different contributing factors as to why perhaps the older generation perceives mental health in a different way.
Right. Among the younger generation, though, are you seeing more young women coming in to seek therapy, or what is the sort of the distribution between young men and young women among those who are seeking therapy? Diary?
Yeah. So I would say women are more, this is my clinical experience, so I don't have data to back it up. But it's just based on my observation and the observation, like from my colleagues. Mostly females and women visit for therapy, which, if I'm not mistaken, is kind of the case throughout the world. Women usually goes and seek therapy, and the Dr. Eva mentioned a really good point in terms of the medical model. There are also individuals who have gotten into the system for treatment, and this is one of the issues that we're facing. They have got into the system in order to get treatment, but they have come out worse. And this is one of the main issues, that people are kind of afraid of getting psychological support and mental health support. And the issue is that the prevalence of the medical model, which is quite fascinating. That is something that's quite as prevalent as it is right now, because throughout the whole world, it's a medical model alone is a failed model. Absolutely, it's a failed model. We understand psychology and mental health and clinical psychopathology aspects of things way better now, and we know that the medical model is not the way forward. That's why psychiatry is going through the biopsychosocial model of providing treatment, which ideally should be the social psychobio. But yeah, they like to have the bio in the beginning, because we have social realities such as social trauma, such as genocide, which form psychological realities such as PTSD, which forms biological changes such as genetic changes or changes in the nervous system. So that's kind of the procedure that it goes through. So that's I think is one of the other issues that people sometimes, they seek treatment, they want to get treated,
Right.
the system harms them, and that's why they really stay away and discourage other people from seeking treatment as well.
Well, it's easy to see why the body might be easier to treat than the mind. Um, even though that may not help in the long run for those who are survivors of trauma or experiencing the effects of trauma. But speaking of the body, do you get clients who are survivors of, say, sexual violence, or is that an experience or a phenomenon that's still very difficult to speak about, or certainly people don't feel free enough to approach a stranger to talk about their experiences?
Here in Kurdistan, I think it's more prevalent than it's been reported. I think based on the data that we collected in one of the universities, sexual violence was reported by 10% of the sample.
Okay.
Around a randomly selected sample, which is still quite high.
It is quite high, but you suspect it's still underreporting the numbers.
Absolutely.
Okay.
Absolutely, because the data we collected was through self-report.
Okay.
It's not like we interviewed folks and they had the opportunity to, to form rapport, to form that closeness, that they felt safer to share their experiences. So I'm pretty sure, which is not very scientific, but I'm pretty sure that it is underreported because it carries a degree of shame, it carries a degree of stigma, it carries degrees of blame. It can be related to honor killings, which is it has been way reduced, but still is a problem in some different regions of parts of our region. So I think for people to talk about, a traumatic event such as, sexual violence in therapy, it definitely depends on the therapeutic relationship,
Right.
because people or folks need to feel safe in therapy. And before even we talk about, traumatic events, which is kind of been the model. For example, in psychoanalysis, you sit down and you talk about trauma. Modern trauma treatment kind of does not work that way. There's a degree of stabilization, skill building, so the individual can regain that sense of safety, and then they talk about their trauma, and we go into trauma processing. So I think it really depends on the skills of the therapist and the therapeutic relationship.
I recall from our last conversation, Dr. Eva, you said it takes maybe between 6 to 12 sessions for someone to feel comfortable with the therapist. And it seems sort of a little bit of a contradiction in there. You want the comfort before you'll take the risk, right? But until you take the risk and hang in there for a while, that comfort is not going to come about automatically. So it almost, I think that's the sort of a little bit of a contradiction in there.
Absolutely. I think what's really important perhaps to highlight here with Kurdistan is that, it's a collectivist society. So, you stay at home until you get married, for example, that's the traditional way. So if we're thinking about actually the traumas within the family, and as an adult, you cannot leave that, environment where perhaps you feel unsafe, it's
Right.
really, really tricky to do that therapeutic work, because, I always think in therapy is that you can help the individual as much as you can with them, but actually if they're going back to the same environment, the same society, the same culture, if you're somebody that is, for example, from the LGBTQ plus community, that's how you feel, but actually, and that's who you are, but you can't go back and discuss that with your family, or you're not accepted by society. There's religion, there's so many other aspects. If you can't go back to that environment, then it is very, very difficult as a psychologist, as a therapist, to do that work with the individual. You can try and support them as much as you can.
That's right.
Context, you've got economy, you've got politics in Kurdistan, you've got culture, you've got religion. There's so many aspects that are integrated into the work that make it a little bit more difficult than if, you know, doing that work in the Western world.
Right. I mean, I understand what you're saying, and there's so many things have to change, right? And then those changes have to reinforce each other to have the kind of effect that you want to see. Diari, can you tell us a little bit about what the current state of mental health services is in the KRI? What kind of training is available, and then what kind of how many therapists are there on the ground right now?
Yeah. Yeah, we can have that discussion in two parts. The first is the making of the therapist, and second the services that are available.
Sure.
So in terms of one of the main problems is that we don't have many psychological programs, undergraduate programs, and graduate programs that are focusing on clinical psychology and psychotherapy. As we discussed last time, this is the reason why I have a bachelor's degree in clinical psychology and I'm practicing. It's because we are trying to fill in that gap that's existing. So throughout the Kurdistan region, there is one undergraduate clinical psychology program in KR University, and they really have a limited capacity in terms of having, having specific and specialist individuals teaching specialist courses.
Okay.
So there are lots of issues there as well. And there's a master's program and a MA program in Duhok University, which is on psychotherapy and psychotraumatology. And there are a couple of counseling programs, undergraduate programs. It's not enough. It really is not enough, because we need more graduate programs in clinical psychology, because you don't want to have like folks graduating with an undergraduate degree and practicing psychotherapy, which is what I'm doing right now, but we have no choice. I think that's one of the main issues, and it relates to that not having many experts, many professors, PhD holders in clinical psychology and psychotherapy. That's why we're not able to have more programs. And there's also always a degree of opposition from some of the psychiatrists, because more therapy may mean less business for them. So it's becoming to be more accepted right now, but definitely there were oppositions, and there's still opposition from them regarding having different clinical psychology programs in different universities. So we have limited programs, we have limited faculty, and this is kind of the main issue behind the lacking of services. Now we come to the other side, which would be the actual services per se. So we have public hospitals, public mental health hospitals. We have one in the Suleymania Governorate, we have one in Erbil, Hawler Governorate, and we have one in Duhok, if I'm not mistaken. So these are governmentally supported institutions where individuals from usually from the lower socioeconomic background go there to get mental health support. And there are lots of psychiatrists, and there are also some therapists, but to a lesser degree. That's kind of in the public landscape. In terms of the private aspect of it, which is usually individuals from the upper middle to the high class, they usually visit these private institutions, and it could be a clinic, and it could be a mental health center. But the important point is that these clinics and centers are only for psychiatrists. So only psychiatrists are allowed in the Kurdistan region to have their own clinics and centers. Like if you have a clinical psychologist with a PhD, from the best institution in the world, outright they won't be allowed to have their own clinic in the Kurdistan region. So we have those sorts of clinics, and before it was just a psychiatrist operating the clinic. Right now, the psychiatrists are kind of more open to having therapists and clinical psychologists working with them. So usually when you see a psychiatrist right now, especially in Suleimania, when you have a psychiatrist working, they have a bunch of therapists working with them. So that's kind of the landscape of it.
Right. If I remember a data point you mentioned, it was 5 therapists for every 300,000 people.
That was wasn't a data. It was more of an observation.
An observation, an estimate.
Yeah. So
based
when
on
we
your
say therapist,
yes.
we say therapist, I mean therapist who would be licensed in other countries.
I see. Right.
We have many individuals practicing. We have individuals with sociology degree, we have individuals with social work degree, we have individuals with engineering degree, and they're practicing therapy because there are policies and specifications to determine who's a therapist, what educational background is required. So I would even say like maybe perhaps 5 therapists for 1 million population if we take that criteria into account of individuals who can be licensed.
Licensed. Yeah. That's an important point. Dr. Eva, can you tell us a little bit about how the idea for the charity came about, and then within the sort of ambit of the charity, this idea for the Kurdistan Mental Health Project came about, and then how you went about building the apparatus and the infrastructure for it?
Yeah, absolutely. So we founded KR-UK-Impakt in 2020. So that's 5 years. We actually started just before COVID, Chris and I. So Chris Bowers,
best time.
Yeah, absolutely. So Chris and I actually met at another project that I was launching at the Parliament in London, and we just had a frank discussion around, the importance of mental health in Kurdistan. He obviously had he's worked in Kurdistan, so he's the British consul. He was the former British consulate in Kurdistan, so he's got obviously that personal experience, and he just had a real interest in mental health. So we obviously spoke about that and discussed what could we do, because we know, I know from personal experience the impact and the need for mental health services. But actually, it was really hard being here in the UK and not being on the ground to know what is available. I've worked, volunteered previously in Kurdistan in Dahuk, but things change. Things change quickly. So we spent quite a bit of time actually researching what was available in Kurdistan. Different courses like the Koya University psychology course, what other organizations are out there, different charities. And we just, had lots of discussions. And then we also, Chris and I met other Kurdish, professionals here in the UK who have an interest in mental health, or, professionals who are, working in mental health here in the UK, but have an interest in Kurdistan, who joined the project. So there's quite a few of us trustees with an interest in Kurdistan for whatever reason that may be. And we, got our heads together with our experiences. So we've got, psychiatry, psychology, political experience as a charity. And it was just around discussions with lots of people in Kurdistan universities, political leaders, for example. And we came up, it just kind of just flourished, to be honest, this idea of we can do anything because, there's so limited.
There's so little available on the ground.
Yeah. Absolutely, that we can try and do whatever we can. So we thought of the idea of maybe using that, the experience that we have and the knowledge we have here in the UK and transferring that over to Kurdistan, obviously keeping in mind that we need to adapt to the culture and to the region. So we ended up developing connections with different universities and with the trainers over in Kurdistan as well. So the ETTC, who are the European Technology and Training Centre, they got board. We lots of discussions with Oxford, so the Oxford Cognitive Behavioural Therapy Centre as well. They got on board, and we ended up just collaboratively coming up with this idea of let's train therapists in Kurdistan on CBT because we know it's a really effective model and therapeutic intervention. We know it works really well, and
CBT is cognitive behavioral therapy.
That's correct.
Yes. Tell us a little bit more about that, Dr. Eva, because is this a relatively new branch of psychotherapy?
So cognitive behavioral therapy has been about, it was developed in the 60s by Aaron Beck. And the theory, really, it suggests that maladaptive thought patterns contribute to emotional distress. So, negative thoughts, they therefore lead to, distress and, mental health disorders, for example. So, which is basically what we do in CBT is try and help somebody recognize those unhelpful ways of thinking and try and reconstruct those thoughts into more healthier ways of thinking. As well as teaching somebody perhaps how they're these negative thoughts. So, for example, if I think that, if every time I leave the house, I might, get in an accident, that's very unhealthy, because then that would lead to anxiety, distress, me perhaps avoiding leaving the house. So therefore, in therapy, what we would do is try and help somebody with those behaviors and with those thinking to try and think of more positive ways that they could manage those difficulties. So that's how I guess CBT works in practice. Obviously there's so much more to it as well,
of course, but I think that is the key is to talk and reframe the ways in which we've understood things for a long time, to try to shift those understandings and reframe those perspectives. And that is why it is called some form of talking therapy. Am I correct?
You're spot on. Exactly. And what I think it's important to note as well is that our past experiences have an impact on our thinking. So if I have been in a car accident, for example, and I've experienced that traumatic event, then I might think, well, being in a car situation, being on the road, for example, that would lead to anxiety. So it's really about helping somebody understand that their thoughts, their behaviors, and the way that they feel physiological, they're connected. And it's about breaking those cycles, really. And we do that through like behavioral activation, thought processes, reconstructing those, etc.
Right. How does the partnership work between the implementing body on the ground, the ETTC, and the training body, which is the Oxford Cognitive Therapy Centre?
So I just want to, say that ETTC have been absolutely fantastic in just the whole project, because without them, this would have not been possible, because obviously they're on the ground in Kurdistan, and they did such an incredible job of finding us the therapists. So they were the ones that advertised for the program and got in touch with the different psychiatrists in Kurdistan, the different mental health centers, and that's they recruited the psychologists, the trainees that we have on the program. So I guess ETTC are they're the organization that try and keep everything together. So they're the ones that organize, for example, the trainees and, the sessions, getting them to supervision, the links, for example. So they do all of that, bringing together the foundations really to keep us going. And in Oxford, on the other hand, they're the ones that are providing the material. So they're the ones that are providing the workshops, the sessions, the training sessions, the supervision. So and I guess as a charity, we kind of are in the middle trying to
Right.
make sure it all works and goes smoothly. So we have our like steering monthly meetings, for example, and, you know, different conversations. So much happens behind the closed doors as such, to make sure it runs smoothly. And obviously we completed our first year of training, which was fantastic, and we have we've learned so much from that first year, and hopefully we take those learnings onto second, third year.
Right. And you have 30 trainees in this first cohort?
Yes, 30 trainees, yeah.
When do you expect them to sort of hit the ground, set up their practice?
So yeah, so some of them already have their own practices. Some of them are already working privately with psychiatrists, in NGOs, in lots of different settings, in the government, for example. Lots of, you know, they're already in their field. And the purpose of the project was to help the therapists in Kurdistan to develop skills. So they're already individual with therapeutic skills.
Right.
But it's to enhance, I guess, their therapeutic skills, particularly in cognitive behavioral therapy. So trying to think about mental health in a different model, a different therapeutic approach.
Right.
So what they would do is have the teaching, go implement that in practice, and then bring it to supervision. So we discuss cases, we go through them, you know, what is working, what isn't working, what could you do differently, for example, and really try and enhance the CBT learning.
There's quite a bit of contextualization that goes on. I mean, there's theory, and then there's the on the ground setting. Can you talk to us a little bit, perhaps an example or an instance where, you know, there were questions coming in from, okay, we understand this is what the theory says, but we are having this issue when we try to apply it, and, you know, so what is the way we can work through this?
Yeah, so I'll just talk. So I obviously I also supervise on the course. So I had a group of 4 trainees there this previous year, and we would have those open and honest discussions in supervision that, you know, it's like this in theory, but trying to implement that in practice can be really hard. So for example, a formulation in cognitive behavioral therapy and psychology is about understanding where the difficulties are coming from. So you're really trying to understand what is happening for an individual through a formulation. So thinking about past experiences, thinking about the current situation, thinking about how they're thinking, feeling, etc. So one thing that was apparent and came up constantly was that when the trainees would do the formulation with their clients in practice, there were difficulties around formulating. So thinking about, you know, trying to get somebody, an individual, a Kurdish person, to think about their thoughts. So when I think this is how I feel, or when I feel this is how I think. That was really difficult for them, because sometimes, you know, in Kurdistan, we don't have the language a lot of the time for, you know, different emotions, for example, or different ways of thinking. So in the UK, and obviously in the English language, we've got different ways that we can articulate how we're feeling and thinking. But in Kurdistan, that's really hard. And sometimes they would have to perhaps say an English word to describe the same English word to mean something, but then describe it. And that can be really hard, I think, in therapy, because if your client is struggling with their feelings and they don't know how to express that, or because they've not been taught, you know, in Kurdistan, you're not, you know, from my experience anyway, my parents never brought me up to talk about emotions or what different emotions mean.
I think we can all relate to some extent.
You know, it's about our own way of understanding that, and obviously I've had to understand it through psychology, but you know, and that's the case for many people. They're not brought up to talk about feelings, or, you know, this is what you're feeling in your body. So that's the difficult part, I think. That's what I found in my supervision sessions, that the trainees really struggled with when doing that formulation work.
So just to make sure I understand, the words do exist, but because we are not used to reaching for those words, or thinking about our feelings in terms of those words, in terms of that, a certain grammar or a certain language, it is difficult. It is not that the words themselves don't exist in the language, because sometimes I know that happens. In my experience in other countries, I know that words for certain concepts do not exist. So is that what you're talking about, or is it that the words exist and people have a lot of difficulty reaching for those words and using those words simply because it's not a habit, it's not part of the culture?
It's a bit of both, Anu. So, I'm sure Diori has, more experience of this, but there's no words to express certain things in the Kurdish language either. So, whether that's talking about different therapy, whether that's talking about different emotion, thoughts, etc. So, words don't exist. So you're trying to, I guess, describe that word,
right,
to the person that you're speaking to your client. But also, it's people don't have, although the language exists, they don't have experience of speaking about those things either.
Sure. Yeah.
But I'm sure, I don't know, Diori, if you have anything further to add on that.
Yeah, I mean, I think I would agree it's a bit of both. And the thing about the Kurdish language is that it's a really rich language, and it's a really diverse language, if that makes sense. In terms of that, we have the Central Kurdish, which is kind of, some people say it's a dialect, some people say it's a specific language, and we have the Kermanji and the Badini dialect of the Kurdish language. Like if I talk to someone with I'm from Suleimani, and if I talk to someone who's from Duhok, I would struggle to understand them.
I see.
So there's that issue as well, or someone from the other parts of the Kurdistan. So
are you saying, Diari, that the degrees of overlap are not much?
Well, for example, there are different vocabulary between the Central Kurdish, which would be, we call it Sorani, and the Kermanji Kurdish. There are different vocabularies, different grammar rules, even different letters. The Sorani is that kind of the Arabic letters, and the Kermanji, they use the Latini letters, like which is used in English. So there's lots of difference and a lot of change as you go through the geographical areas. As with my experience with the Sorani dialect of the Kurdish language, I think we have many of the words, but they're not the words that are used in conversation, because our region has experienced a lot of attempt at cultural and ethnic cleansing. So the words from the Arabic language, from Persian, these words have come into our language, and sometimes it creates like a mix. So we can like see it as the influence of this, that some of the words that we have in the traditional Kurdish dictionaries, but not many people know it. So that there should be an attempt at getting these words more public, more usable, getting them into academic writing, and which is another issue, because academic writing here, if you wanted to get noticed, it has to be in English. So I think that would be quite a discussion in relates to psychology in Kurdish language, which is an area of discussion in itself.
I understand what you're saying about the need to contextualize and how difficult it can be. And yet, when I hear you talking about the project and how you structured it and how the basic infrastructure works, I feel like there's something replicable inside the model that you've come up with. Do you feel the same way, Dr. Eva?
Absolutely. And that is, what we want to do, is what we want to replicate what we've done in in Kurdistan into other parts, whether that be Syria, whether that be, other parts of Asia or the Middle East, for example. And I think what's replicable with our project is that we have a model where if we have an organization that we're working with on the ground in Kurdistan, we have connections to different organizations, universities here in the UK. And because we can see it working, and we've seen that it worked, the first time around with Oxford, we can replicate that with other universities here in the UK. So we have a bit of a model that if we can get an organization in Kurdistan or, in a different part of the Middle East or Asia to do that work, we can, develop the connections here to collaborate on something really special.
Right. Is that something you're working on right now? Is that something, that's an aspiration?
Yeah, well, we're having those discussions already about other regions. They've come definitely into discussion. We're already looking at perhaps looking at other universities that we could work with in Kurdistan as well. And I think, we spoke about this last time, but, as Diori said, therapists in there's no regulatory body that, says, okay, you're a therapist, or, you are this type of therapist, or you're a psychologist. So what we want to do is make sure that we're building I guess that body to really help change mental health and psychology and therapy in Kurdistan. So and we do that, I think one of the ways is working with the governments, but also with different universities, and we're having discussions. But yeah, we shall see what happens.
So that would be sort of on the regulatory board kind of thing that you're talking about.
Exactly.
While I see how the pieces are falling in place and the larger plan, but I'm wondering what the livelihood prospects are for therapists, licensed therapists on the ground. Is this a line of work that someone would pursue out of, even though they have to pay a personal price for it, in that it's hard to make ends meet, but they're doing this because they understand the urgency of the situation? Or is it a line of work in which they can actually make a livelihood, and therefore that line of work becomes attractive to more young people?
In terms of therapists in Kurdistan region, I think worldwide, for example, in the US, the clinical psychology PhD programs are one of the most competitive programs. They're really hard to get into. And that's because, there's a high demand for therapy, and it allows individuals or folks to have generate a fairly good income from it. I think the situation is quite different here in the Kurdistan region. For example, like a session in the US may be ranging from $200 to $300, whereas here in Kurdistan region, a therapy session may range from like $15 to $30. Which is quite a big and significant difference. I think some of it relates to of course, it relates to the socioeconomic context of the country, but definitely you could make a case that therapists are really underpaid. But more and more people are trying to get into studying clinical psychology. We have individuals studying, for example, developmental psychology or general psychology, educational psychology as their undergraduate studies, but they want to pursue clinical psychology in their postgraduate studies. And this is the reason behind this mainly is that they see clinical psychology as having more career prospects and having more opportunity in terms of work. So that the kind of the situation for the clinical psychologists, which is not ideal,
Mhm.
but the other branches are also all trying to get into clinical psychology better, because at least there's something to do with it.
That's right.
So I think the current model, it's definitely not sustainable for therapists. Individuals are working, but the way I see it, working in clinics and mental health centers, if you do a research, it definitely would be a predictor of burnout. Again, definitely is not too scientific word, but you get the idea, and that's kind of how it is. And then the model that which is usually being used here is that you work in a clinic, and the model of work is I call it a psychiatrist-centered model. So the clinic, most of the clinics, let's not say all of them, most of the clinics and mental health centers are created in a way that are aimed at benefiting the psychiatrist business-wise. And like you could make the argument that the money that a therapist makes in a month, a psychiatrist can make in a day, which kind of showcases the huge difference and in terms of the payment. So I definitely do not see the current model as being sustainable. And another problem is that the absence of insurance is not a thing in our country, and people pay out of their pockets for private services. Yeah,
Okay.
and so yeah, I don't see it as a very sustainable model, and it definitely needs work.
Well, despite the difficulties, I think, Dr. Eva and Diari, your work makes the world a better place. So thank you so much for that. Before we end today's conversation, let me ask, are there specific actions for the younger generation to take? I mean, what can they do to continue to raise awareness of mental health in the KRI, or how can they get involved in the work of KR-UK-Impakt? What can they do to get in touch with you if they would like to have a conversation? Perhaps somebody in a different part of the world with the same needs and might like to pick your brains. What can the younger generation do, and how do they get in touch with you?
So for me, it would be just to talk, have conversations about mental health, about how you're doing, whether that be with family, whether that be friends, with your teachers, with people in your community. Just talk about it. I think that's the number one thing we need to accept that it's there and it exists amongst us, and we all have mental health just like we have physical health. And if we can just acknowledge that and accept that, I think we're on good tracks. And to just ask for help, because there are so many people that are there to support you. We have, from my research, I know we have like social workers in schools. We have different professionals that would listen, and I think that's really, really important. Seek out that help and talk about it. And if anyone wants to have any discussions about the project, particularly our charity and the work that we're getting up to, if I always welcome different ideas in terms of what we could do, what more could we do, what else.
That's right.
For us, please do get in touch on our website. If you just type in KR-UK-Impakt onto Google, where we should come up, and I'm sure I know in the description we can give you the link, and you can. Of
course, we'll do that. Yes.
So yeah, just get in touch, share your ideas. There's no such thing as a right or wrong answer or question. Just get in touch and let's talk about it.
Dr. Eva and Diari, thank you so much for sharing your knowledge, your work, and your commitment with us today. We will be in touch. At the Global Center for Youth Futures, we wish you the best as you move forward with the project. And that's it for us today. Until episode 3, bye-bye.